I'm Dr. Ebonie Vincent. I'm here at the Indigo Hotel in Los Angeles. I am here with Dr. Michael Lalezarian. Did I say that right?
Perfect.
So perfect. Okay, great. Dr. Lalezarian is a medical doctor and a specialist in vasculature. As podiatry, we closely work with our vascular surgeons to save our patients' limbs and lives. So can you just walk us through how we work together?
Yeah, so peripheral vascular disease has reached epidemic proportions really because of the rise of diabetes, and the marriage between podiatry and vascular is incredibly important because podiatrists are on the front line in identifying the earliest signs of peripheral vascular disease. So I work very closely with podiatrists and wound care physicians and identifying the disease so that I can get them into my practice and we can put them through the correct treatment algorithm and potentially save a limb.
Right. So normally I'm seeing patients that come into the office usually for a wound. Usually they're there, they have a small wound, and we do the examination. We realize, okay, well, we don't have much blood flow, and then we send them to vascular. A lot of times they're wondering, well, what is the vascular surgeon going to do? Do I need surgery? What happens? So can you walk us through when you first see a diabetic patient who is referred to you by podiatry? What happens?
Yeah. So causes of wounds are multifactorial. The first part of my algorithm is to determine what the cause is. Because once we identify the cause, we can really optimize treatment. And so many wounds are arterial and venous combined. So I would try to identify the dominant factor in that case. On the venous side, it's usually a problem of blood leaving the foot or getting out of the foot, and therefore closing the veins that aren't returning the blood well or are refluxing, as we say. By closing those, I get really good results in terms of wound care. On the arterial side, it's a problem of not getting enough blood to the foot. So in that case, I'd open up the artery, revascularize the artery, open the blockage, and any way to get blood to that wound bed for optimal wound healing. And I would work closely with the podiatrist in parallel. They would provide the wound care, and I would provide the circulation.
Right. So in terms of a venous stasis ulceration, compression therapy is what we would typically recommend in conjunction with a possibility of a more minimally invasive surgical procedure that could definitely help you. How would you decide if a person would benefit more from a vein ablation?
Okay, so great question. Venous ulcers are incredibly common, and the first line treatment, as you said, is compression and elevation. CMS requires 3 months of compression before they'll consider more advanced treatment options such as ablation. So after I've compressed that leg for 3 months, then I will proceed with ablation. Most of the time upon referral, that patient has already been in compression by podiatry. So as long as we can document and kind of say that we've had a good faith effort in compressing this wound, I'll proceed then with ablation.
What are your thoughts on compressing therapy, whether it be sequential compression, Pro4, Uniboots? What are your thoughts on those?
So I leave that up to the referring doctor.
Okay.
But really, ultimately, any type of compression will be beneficial. 30 to 40 millimeters of mercury, knee high is fine, thigh high is better, but sometimes I know if I recommend thigh high, I'll get less compliance with the patient, so I try to keep my recommendation realistic as well, because really any amount of compression, it really makes a difference. So compliance is more important than what type of compression garment it comes from my standpoint.
Nice.
Yeah.
And so in your presentation, you had an example of a percutaneous angiogram and then a more invasive, open surgical stenting process. Can you kind of describe the difference between the two? Who is necessary to get the more invasive procedures, and why you think a more percutaneous procedure could be more beneficial?
Okay, so in 2020, percutaneous minimally invasive approaches have really replaced surgical bypass as the first-line treatment. Firstly, it's a small puncture. Patient walks out of the office that day. It's an outpatient treatment. The costs are significantly lower. The risks are lower. And so it is first line. at this point. Surgical bypass still plays a very important role, but it's really for cases that are refractory to endovascular percutaneous attempts first.
Okay.
I still have to resort to that option, but we always try endovascular percutaneous first.
Okay. So my other question, probably the last about the arterials, is to stent or not to stent. So I know there's been some kind of, you have to have like a criteria to stent, is that correct? And then there's certain patients that get a stent that are more prone to having that stent collapse, is that correct too?
Yeah, so you're asking high-level questions here. There's a tremendous amount of research and thought that goes into these treatment decisions, and to answer it more simply, the more chronically occluded and longer the blockage is, the more likely I will place a stent. The data shows benefit when the occlusion segment is long, when it's calcified, and when it's been blocked for a long time. So otherwise, I don't like to leave metal in the body when not necessary. Stents can cause problems in the long run. They can reblock or restenose over time. So I don't make that decision lightly to place a stent, but there are certain scenarios in which the primary patency at a year out, for example, is better if there's a scaffold behind or a stent.
Right. Okay. Well, can you tell us a little bit about your practice, where you practice, and what kind of patients you're seeing on a daily basis?
So I see all sorts of peripheral vascular disease, arterial and venous. I work with a lot of wound care practices, and it's in the Los Angeles area, several locations, really to offer an opportunity for patients in different geographic areas to have access to care. Access to care for these patients is a huge problem. Yeah. And we know that, and oftentimes they have limitations to transportation, and so by being close, I'm able to access more patients. And so throughout Southern California, 5 different locations, and you can on www.provascularmd.com find some more information there.
Perfect. And thank you so much for your interview and for working closely with podiatry and the efforts for limb salvage.
Thank you,
I really
Ebonie.
Appreciate you.
My pleasure.
All right, take care. Thank you.